we'll talk briefly about sound energy, and then I'll talk about resolution. I'll talk about modes of echocardiography and the Bernoulli formula, and then some hemodynamic calculations. And I think that'll be about it. There's a heck of a lot more I could talk about, but I'll have to do that in separate lectures. So before we get started, I need to make some acknowledgments as per our recent discussion on the RCH anesthesia disclosure policy. So in full disclosure, to avoid any real or perceived conflict of interest, I will attend educational sessions in Belgium with a local RCH surgeon. I will advise the group when that is confirmed and make a presentation with said surgical colleague upon return. So I think the person who drafted this is actually in Europe right now, so we'll have to see if he what he brings back with him. A bit of an inside joke. I apologize to those that aren't inside. The other things I want to acknowledge are the websites that I stole a lot of this information from and the graphics. So PTE Masters is a great one, study for perioperative echo. There's a Canadian Society of Echocardiography, and then of course Wikipedia and Google Images. So as you all know, sound is a mechanical longitudinal wave, and you can contrast that with electromagnetic waves, which the movement occurs perpendicular to the direction of travel. So sound is a series of rarefactions or expansions and then compressions. And this is obviously vibrating through some medium, which in this case is our tissues. And so I found this website with this video of sound waves, and you can see that the sound waves are moving to the right, and the movements are from left to right, okay? And that's a little bit different than transverse waves. So I'll show you now transverse waves. So the movement is perpendicular to the direction of travel, which in this case is from left to right. You can see the wave fronts moving from left to right. Okay, so that's just some fun stuff on waves and how they differ. So sound wave is not a transverse wave, as I mentioned. It's a mechanical longitudinal wave, but we often discuss it as a transverse wave because it's a lot easier for us to conceptualize. So on the right is a transverse wave with its typical crests and troughs, and then there's a wavelength and an amplitude. And on the left is sound waves, where you have the compressions and rarefactions, and you can see the wavelength is represented in between. So just a little bit of a difference between sound waves versus normal waves. And more review for most of us. Ultrasound is greater than sound, so it's greater than 20 kilohertz. And audible sound is 20 hertz at the base level to 20 kilohertz at treble. So that's audible sound. And then, we can talk about attenuation of sound energy. And as we increase the frequency, we're more susceptible to attenuation as the waves travel through tissues. And we can discuss properties like amplitude and power. And as our depth increases, the amplitude and the depth, or the power, decreases. Some other properties you probably all heard of. You can discuss waves in terms of time, in terms of their length, or in terms of the signal strength. And so time, you're familiar with period and frequency. With length, we're familiar with wavelength. And then the things I mentioned, the power, the amplitude, and the intensity. Interestingly, the intensity of sound energy is what's associated with the bioeffects. So intensity is the power over a unit area, and when that increases, that's when we have to consider the bioeffects and when we'll be disrupting tissues. So obviously that's important with obstetric ultrasound, and we'll want to be careful with that power over a unit area. All right. So now I'll shift gears to resolution that we should consider when we are using ultrasound machines. So basically there's two major forms of resolution, spatial resolution and then temporal resolution. So within spatial resolution, there's two that are similar, and that's lateral and elevational. And then there's one that's slightly different, axial resolution. And axial resolution is some distance away from the face of the probe. And you can see the diagram in the top right. Axial is Z, and then there's elevational and lateral. And resolution is the ability to discern the correct place of a structure. So we're not fooled by something. It's actually, it is what we see. So that's resolution. And before I talk more about axial resolution, I just need to mention briefly how an ultrasound works, and I'll sort of jump around a bit, but I need to discuss this in order to discuss axial resolution. So the ultrasound, the ultrasound sends out a pulse, and then it listens. And then it sends out another pulse, and it listens. And this is not to scale. The listening time is very, very long, and the pulse duration is very, very short in comparison. And this becomes important because there's the spatial pulse length. So that's the duration right here that I've shown. So this is obviously one wavelength, and then you've added three of them together. That's a pulse, and that length is the spatial pulse length. And that is what we'll come back to later, this sort of stuff. But that's what's important for axial resolution. And this cartoon tries to represent axial resolution for us. And it's just a dramatization. But in the top frame, we have a spatial pulse length, which is longer. And then down here, we have a short pulse. And you see, this is what you see on the ultrasound on this scene. And over here is what is represented by the heart. Again, it's dramatization. You won't just be able to see this way unless it's very, very tiny. But here you have a very small pulse, and it's sent out. And there's an AST, and then that's just represented on this side. But over here we have a larger pulse, and it's sent out, and the AST, it doesn't bridge that. It bridges that gap, and therefore we lose that resolution, and therefore we don't have adequate axial resolution. And so axial resolution is equal to 1/2 the spatial pulse length. So that's something that we need to consider when we're designing ultrasound machines. And again, this is a dramatization. ASD is not again, they're usually large enough that the pulse length of the device is not going to limit your view. This is more on axial resolution. So in the top frame, we have two images that we're distinguishing as two separate images, and in the bottom frame on the left, we're sort of blurring the lines between the two, and this is an interesting aside on transducers as well. On the right pane, there's two different transducers, and you can see. I don't think I can bring up an arrow, and I don't think I have a pointer, but this is the element transducer, and you see it's thin here and thick here. And what happens is it rings back and forth, and some of the energy is at the end of the transducer, and that will affect the wavelength. Design this element affects the wavelength that the transducer makes. So if the element is very narrow, then it's going to ring back and forth quickly, and you get a higher frequency transducer, as it says on the bottom. And if the element is a little wider, then we'll get a lower frequency transducer. So that's some interesting stuff on transducer design. And again, that'll affect the wavelength, and it'll affect, if we have three pulses together, it'll affect the spatial pulse length. And that, again, affects the axial resolution of our image. I think I've touched on all of these things already, except to say that with higher frequency transducers, we have greater attenuation in the tissues. So when you're reaching for an ultrasound probe, say for spine imaging, and you want to image deeper into the spine, you're going to want a lower frequency probe, so that the wavelength is a little longer and it'll image deeper into the tissues. However, you'll lose axial resolution because your spatial pulse length is going to be longer because your wavelength is longer, right? So in that case, you want to try to do an interscaling block and the nerves are very close to the surface, then you're going to select a higher frequency probe. So that's sort of where some of that decision-making comes from. Does anyone have any questions about that? I should mention anyone. Feel free to be interactive if you want. Okay. Did I disagree? Yeah, gotcha. I'll talk briefly about lateral and elevational resolution. They're somewhat similar. They're based on the design of the probe face. And so lateral resolution, this also brings up another point, is the focusing of the beam. And we'll talk about that in a moment. But lateral resolution, this cartoon represents, you can see here at the focal point, two objects are being discerned as two different objects. So we have adequate resolution or resolving power at that depth. But if we're in the near field or in the far field, you can see here the two objects are too close together, and in this cartoon, they're not being distinguished. They're separate objects, so our resolution is not adequate outside of the focal range. So, and again, the lateral or the elevational resolution depends on the beam width or height, right, and respectively. So now I'll shift gears and we'll talk about temporal resolution. Temporal resolution is really important to keep in mind when you're optimizing your imaging as well. So temporal resolution depends first on how fast the object's moving, and then secondly on a number of parts of our system. Okay, so I jump around a bit, but this is 2D imaging now. So that's what the cartoon on the right represents, or the diagram. And so each of those lines coming out from the probe, the green thing, is the scan lines. And so if you have a lot of scan lines, I used to think when I started using ultrasounds a lot during my fellowship that we should get a faster machine. We'll be able to get a faster frame rate, but it's not necessarily the faster processor that's the issue. It's the listening time is so great. As I mentioned earlier, there's a pulse, and then we listen for a long time, and then we have to send out another pulse, and we listen. And it has to do it along each scan line, and also to each imaging depth or foci along the scan line. So it's not just a limitation of processing power; it's actually physics and listening time. Okay, so the frame rate is going to be affected by the depth of our image, the number of scan lines that we demand for adequate resolution, and also the number of foci per line, which is a little bit more complicated. And then the sector width. As you know, the ultrasound is a bit of like a pizza, and if we narrow the sector, then we're not having to scan as many lines, and our frame rate's going to increase. So in the top left-hand corner of image, you'll often see the frame rate written, and you should take note of that on echocardiography. So this is a video that I stole from the PTE Masters website, and what it does is tries to demonstrate a reduced frame rate. So you can see there's a lot of extraneous space that we set the imaging depth very deep, and therefore the frame rate up here says 6 hertz, okay? And that's because we're having to scan all this wasted space out here, we're telling the computer that there's information there. And now what they've done is they've set the frame rate lower. They've set the imaging depth lower, and they've been able to increase the frame rate. You see it's less choppy, and it says it's 20 hertz here. The frame rate's a little faster. The other thing they did was they did what's called color compare. So you have grayscale or 2D imaging on one side, grayscale as well on the other side, but overlaid with color flow Doppler. Okay, which we'll talk about later. And that's there's a lot of processing that's having to go on with scanning, and therefore the frame rate went right down. Does anyone have any questions about that? Frame rate and temporal resolution? Yes. Yeah. Pardon me? It's good. Yeah. No, it's definitely good. It's good to I did use a lot of color flow Doppler at the beginning, and then you start to realize, look carefully at 2D and look at the actual structure, and then you can predict what you're going to see on color flow Doppler. And so that's a bit of an aside, though. So imaging optimization, this is some of the stuff I've been getting at, but when you are looking at an image, you want to decrease your depth to exactly only the area of interest. You don't really want to go deeper than you have to. That doesn't mean you want to look into such a narrow fashion that you miss some obvious fluid collection distally, but you can start broad, but then narrow your region of interest to just the area of interest. You want to narrow the sector width. If you look on your machine, and there's going to be a knob where you can turn the sector width in, and that'll increase your frame rate. And then you want to, there's also another knob for focus, and you can see it on the right-hand side of the screen often. There'll be a little slider that moves up with the focus, and you can slide the focus just to where you want to. And that's important for, and I'll get to that in a moment, but that's obviously important for regional anesthesia. So we're back to this again. I probably don't need to belabor it any further, but I want to move into something called the Nyquist limit, or the Nyquist frequency, and that again ties into this pulse repetition period and frequency. Okay, so again, there's a pulse, there's listening, the whole time. It's called a pulse repetition period, and I'll inverse of that is the frequency, and that helps. That determines the frame rate. And again, we increase this listening time and we increase our depth because we're saying, well, we're interested in hearing about reflected signals longer than that. So there's something called the Nyquist limit, which I'll touch on in a moment, and that is 1/2 the pulse repetition frequency. But before I talk on the Nyquist limit, I need to talk about Doppler shift. And you've probably all come across this. You hear a train when it's coming towards you and then it passes you. There's a change in the frequency. And this is the equation. I don't mean to intimidate you with it, but this is the equation that we use in echocardiography. So there's a change in frequency that occurs. And this V is the velocity of the blood that we're imaging. The cosine of theta is the component of that vector that's relevant to us, that's moving towards the probe. And then there's the frequency of the transducer, FT. And 2 times is because it hits the blood once and then it's reflected back. I never quite understood that. I'm sure Michael will explain it to me afterwards. But there's 2 Doppler shifts occurring when you're imaging blood. And then C is the velocity of the sound within the tissue. So the interesting thing about this equation to note is that the FT, the frequency of the transducer, is on the top. So if you have a high frequency transducer, then that number is going to be larger, and you're going to experience more Doppler shift. So Doppler shift is more of an issue when your transducer is high frequency. When you're low frequency, there's less Doppler shift. Okay, and that could be. I'm not sure if that was just more important on the exam or in real life, but that can be something to keep in mind because your Nyquist limit, which we'll touch on, and your pulse repetition frequency are set, but the Doppler shift that you experience is also something else to consider. And so you'll get less Doppler shift with a lower frequency probe and less aliasing, which we'll touch on right now. Okay, so I wanted to describe aliasing, this concept of aliasing and Nyquist limit. And I found this on Wikipedia. So this is the wave that we're trying to measure, the red wave here, okay? And we're trying to measure that wave. And the Nyquist theorem or limit would suggest that we need to be twice the frequency in order to accurately measure this wave, okay? To accurately plot points on it. And so what happens if we sample it at less than the Nyquist limit? Well, you see here, we sampled once, and then if we sample again, but we don't really sample quite fast enough to make it back to where we were, then we'll get a point here. And if we do it sometime later, we'll get a point here. And we're getting all these points that we're measuring on the wave. And so if we save these data points, and we later go to reconstruct this wave, in fact, we get a much lower frequency wave reconstructed from this high frequency wave because we've sampled it so poorly. And that's called aliasing. And that's because we didn't sample that higher frequency wave at least twice the frequency of that wave or at the Nyquist, above the Nyquist frequency or limit. Okay. Right. Yeah. I used to watch Airhawk, and there was a helicopter flying, and the rotor would spin one way and then the other, and I never understood it. But the camera is is it 30 frames per second, and it's shooting away on this main rotor, and then if the rotor changes, it would come back the other way. So it's not a wagon wheel for me; it's the Airhawk main rotor. Yeah. So yeah, that's a good way to put it. I guess as a more of an electronics engineer guy, this was more relevant to me than wagon wheel. So I just want to demonstrate aliasing now in color flow Doppler, and this is I found this on the web. I think it's a echo of a dog, which is kind of cool, and it's some kind of parasternal, almost long axis. And so what we have here is the LV, and they put the vector of color flow Doppler on LV and LA, and we've got some bad regurgitation going on from the LV across the mitral valve back into the LA, and you can see there. This is an important scale which maybe you haven't paid attention to in a while, but this is 0 meters per second, and then blue is away from your probe and red is toward. And so if you have flow away from your probe, then it's going to be blue, and if it's towards the probe, it's going to be orange to yellow. Okay, and here we have a bright blue, or a light blue, and a light yellow, and you can see that they exist together within this net of turbulence here, and that's alias. You couldn't really have a yellow and a blue right next to each other. Of course, you could have turbulent flow, and then maybe that would happen, but a lot of that is to do with is from aliasing. Okay, and in fact, this software shows white if it's from one way to the next. So that's aliasing for color flow Doppler. And so we also have to keep in mind of our nitrous limits, which are these numbers here, 0.61. Often it's represented in centimeters per second, so it'll be around 61 centimeters per second instead of 0.61. And this is actually a pretty good rate, in fact. So, yes. Oh, yeah, makes sense. Sorry, guys. Yeah, that's no good. I wish I could use my. I'm doing a lot of touching the screen. I'll try not to. Okay, so anyway, that's aliasing there. And again, so when you get aliasing, you need to look at the side, the scale, and see what scale do I have, and is it a good enough scale? Because you can imagine if I adjust that scale such that it's a third of that, then we're going to get a lot more aliasing easier. Okay, and so there you push CW, which I'll get to. There's no aliasing in CW, Richard. Yeah. So enough said on that. So, but that can overstate how much regurg you have, right? So you really need to be careful with the limits. I think so. Yeah, 11-year-old terrier. Yeah, yeah. So I'll switch around now to, we've talked about grayscale imaging, we've talked about color flow Doppler briefly, and now I'll talk briefly about M-mode imaging because it's actually pretty cool. And it wasn't the first mode of imaging that I really tinkered around with a lot. But M-mode imaging, on the x-axis there's time, and on the y-axis there's depth, and then the brightness affects the strength of the reflector. Okay, so here is here's M mode, and say we want to, there's a little dotted line cursor you can see drop down through the center of your pizza, I guess, or your sector, and that's your intonation line, or the line you're going to listen across. Okay, and so it's been dropped down through the aortic valve, and as it opens and closes, I've stolen this too from this PT Masters website, which is very good. And so there's M mode, and you can see in the near field or the top part of your graph, there's the left atrium, and then you've got the aortic valve. And sorry, Eagle Ridge, but here's a nice box here that opens and close here in diastole, and starts, and the aortic valve opens, and it's a nice shoebox, and we can measure the length of systole if we wanted to, or diastole, and that comes into play for some more advanced topics. And then, so say we have a patient with HOCM, or obstructive cardiomyopathy, their LVOT will essentially occlude in late systole, and therefore some of the blood flow to the aortic valve will actually dry up in late systole, and you get a coarse systolic fluttering that we can see with M mode. So we've dropped the cursor line down, and you can see here that it flows in diastole, it opens in systole, early systole, and then it starts to close as some of the blood flow dries up, because here in the LVOT, it's so hypertrophic and obstructing, it's actually fluttering and causing the aortic valve to close. So yeah. No, interactive is good. And I can, yeah. So M mode's very useful. And you notice you have an ECG along the bottom if you bother to either plug it into your machine or put on the ECGs. It's very useful because, and don't be afraid to use the freeze The freeze is not just an annoying thing that happens after you don't use the machine for 5 minutes, okay? It's actually really useful. Just push the freeze button, you're going to know where it is, and now you'll be able to have a look at the timing that you're noticing, and you see your ECG, and you can, in fact, see that beyond the QRS is obviously systole, and in fact, that's when we're noticing some of these phenomena I'm mentioning. So that's a pretty good mode to play around with. Here's another example. And I just wanted to show you another mode. This one is for what's called fractional shortening. This is a very basic EF, or a very basic Simpson's method. It's not Simpson's method, but it's a very basic measure of systolic function. So what we've done now is we'll get a short axis, parasternal short axis through the left ventricle, which is easier to do than you think in some patients. And so you can throw the probe on, as I've stolen from this Toronto website. I should reference that. Cutting the left ventricle in short axis, and we have a nice donut on the right side, and we've put down the ice pick line and through the middle, and now we will develop this graph, and we can see from diastole to systole how much contraction or shortening has occurred, and if it's greater than 25%, that would be considered normal. Okay, so again, this can be misrepresented. If you have an apical aneurysm or wall motion abnormality, then you're not really capturing that there's a problem in the apex of the heart. So it's not a perfect method, but it's just something to note. Right. 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 Yeah. Yeah. Fair enough. Gotcha. Yeah. It's a measure of LV, systolic function. Oh, I think this slide got messed up. It says hokum up at the top, but anyway, we've covered this stuff before. Not that I know. If you're, it's typically done in short axis. In long axis, you can measure the end diastolic diameter of the LV, and you'd measure across the chorda tendineae between the PAP and the mitral valve. So there are guidelines on where you should be measuring. And M-mode's a great way to measure. Rather than just push freeze frame and think, okay, probably I caught it in diastole. Well, if you M-mode it, you can then move along and say, that is exactly where it's widest. That's diastole. That's the measurement I'm going to use. So it's a really elegant thing to use. I've used it for tamponade. If you're wondering about some wall that's wiggling and you're wondering if it's sort of, if there's diastolic collapse, then you could put M-mode on that wall and then break it down and see. It probably should be more of a clinical diagnosis than what I was doing, but it is interesting. Yeah. I guess I've somehow put this slide in. This is 2D imaging, but I want to add in the concept of phased array. Okay, so we'll talk about that in a minute. So as Guy mentioned, M-mode was one of the first kinds of imaging, and then they added a whole bunch together to form a sector and grayscale or 2D imaging. Okay. And it takes many times, you have to scan many lines, and therefore your temporal resolution is not going to be as good as with M-mode because you're having to scan all these different lines and create an image. And that's what I've shown you this figure before. That's why it's slowed down as far as the frame rate. I want to talk about phased arrays. So those PZE, the piezoelectric elements, that's an array of elements, okay? And then the phase is obviously when things are triggered or when the ultrasound pulse is emitted from each of those elements. Okay, so we have electronics on the left and we have time delays, and so we can trigger each of those elements individually when we want to, and that's an array and in certain phases. So we can either steer the ultrasound wave or we can focus it, or do both perhaps. But steering is on the top, and I've seen this implemented with regional anesthesia when you have a linear probe and you want to steer it such that the beam is more perpendicular to how it hits your needle. Okay, and that way you'll get better reflection off your needle and you'll be able to visualize your needle better. Okay, so that's called phased array steering. And then the bottom is focusing, which we use for, I think, all kinds of ultrasound imaging. What we're going to do is trigger the outer piezoelectric elements first, and so they'll have a head start, and those wave fronts will move out from the outsides, and then we'll trigger the insides later. And so that's how we get a wave front that's sort of converging on each other towards the focal point. And in fact, if we change the timing, we can change where the focal point is, whether it's in the near field or further in the far field. Okay, and this is representing it again. On the left-hand side, we have a focal point which is more distant, and then in the middle, it's a little more closer in the near field, and then on the right is where we're steering it upwards. So I'm going to change gears yet again, and I want to talk about continuous wave Doppler and pulsed wave Doppler. These are two different new modes. We have M mode, we have color flow Doppler, we have 2D grayscale imaging, and now I'll talk about continuous wave Doppler and pulsed wave Doppler, okay? Which are also known as spectral Doppler because they allow you to capture the spectrum of sound frequencies, okay? So they're slightly different. The CW is in the left probe there, and it basically has two crystals, one that's transmitting like crazy and the other that's listening like crazy all the time with no breaks. And therefore, it doesn't really know where it's receiving the sound waves from. It just knows it's somewhere along the line that it's looking on, but it knows that it is receiving all the time and it's transmitting all the time. And therefore, aliasing and there's no relevant Nyquist limit for CW. With pulsed wave Doppler, there's a little blue dot there on the right in the image, and that's our gated sample space, if you will. And so what it's going to do is send out a pulse, and it's going to close its ears until a certain time period later when it thinks from that depth I should be receiving information about now, and it'll listen at exactly that point. And we can vary that point, and that's called pulsed wave Doppler. And that is quite limited by the sample rate or the Nyquist limit. But it is very useful because we know exactly where we were listening. So there's an upper limit to how fast we can measure blood flow with the pulsed wave Doppler. Okay, so this is a typical continuous wave Doppler trace. And so there's the yellow or orangish baseline down the middle, and that is 0 meters per second. And if the blood is moving away from the probe, then you're going to have a downward deflection, as we note here, primarily. And if it's moving towards the probe, we're going to have an upwards deflection of your CW. And so that's how that works. Also, CW captures all the velocities along that incination line or the dotted line in the top little inset image, and therefore it's going to be filled in, the graph, okay? Because it's capturing all velocities from low to high as it's moving through. There's a bit of a narrowed orifice here, the aortic valve, and so as the blood accelerates, as it reaches that valve, the peak velocity will be right here, and then all the lower velocities will also be captured in the graph, okay? So I mentioned this stuff. It uses two crystals, and it's not limited by pulse repetition frequency or the Nyquist phenomenon. So it's very useful for high velocities. If you have aortic stenosis, where the velocities could be 4 meters per second or faster, you're going to need to use CW. Okay. And I think I've added yet another slide. I don't know why I added. Oh, this one I wanted to illustrate that you can push freeze after you do this, and then you can pick trace. And what someone's done is traced out the envelope of this CW measurement. And in fact, and then the computer spits it up top here, your maximum pressure gradient, your mean pressure gradient, and you can use those numbers to determine how bad your aortic stenosis is. This stuff is these measurements are very severe. I've never had them that severe myself, thankfully, for not having to anesthetize a patient like that. But you can use those numbers. The mean is particularly useful for looking at the severity of aortic stenosis. So don't be afraid to do that with your transthoracic echo, which I'll get to in a moment. And then again, I'll talk about pulsed wave. There's some time. You can see there's an arrow going out a long time and then an arrow coming back, X. And so it knows the time that it takes to travel in most mediums in our body. And so then it's able to figure out a gate. So that's also known as range-gated Doppler. And so this is a typical pulse wave Doppler image. And you'll note that it's more of an outline now. The middle section of the graph is missing. It's black, and there's only what we call a modal velocity. And that's because it's only measuring at a certain point. And here's what you can't see very well, but there's a little gate here, and the aortic valve, and they're measuring now. And so now we're measuring that point only on the back. So we're not picking up all the slower velocities as the blood accelerates faster towards that LVOT, and that's why it's not filled in. Okay. So I want to talk now about how am I doing for time? Oh, maybe I got it hurried up. The simplified Bernoulli equation. This is some interesting physics that allows you to take a velocity and figure out the pressure changes within the heart. Okay, so it says that a change in pressure is equal to 4 times the velocity squared. And that's called the simplified Bernoulli equation. And there's some factors for viscous losses and acceleration, and that's just sort of out of interest. We sort of consider those negligible or work it into the constant of 4. Thankfully, it's just 4. And so it's a very good equation to remember. I remember Doug taught it to me, and I remember that clearly the day I learned. So it's used to calculate intracardiac pressure. So we'll do some of those examples in a moment. There's a little bit less simplified Bernoulli equation, and that takes in the proximal velocity. So if you're lining up an insination line down the middle of the LVOT into the aortic valve, you're going to have a velocity 2 across the aortic valve, but a velocity 1 will be in the LVOT as things start to accelerate faster towards the aortic valve. Now, if that velocity is less than 1 meter per second, then you're going to square it in this top, more complex equation, and therefore that 1 is going to get even smaller. So what I'm getting at is if your proximal velocity is less than 1.5 meters per second, we call it a rule of thumb. We don't worry about the proximal velocity. And I won't say anything more about that today. I don't want to confuse people if you haven't seen that concept before. This is just a diagram again of a funnel-shaped LVOT funneling into the aortic valve, and if the proximal velocity is too fast, which it usually isn't, then we can't use that very simple formula. I think I was trying to belabor that point even further here. And here as well, this is called continuous wave Doppler, and someone's traced out the more proximal velocity right here, and you can trace over to the graph. It's around less than 100 centimeters per second, so less than 1 meter per second, we're okay. Can talk about that stuff more in a minute. So now we want to talk about stroke volume, okay? We all, you might have thought, well, you need a Swan-Ganz catheter to measure that. Well, it's not true. You can do it with echocardiography. So stroke volume is just a volume, and we need to find out an area and then a distance. So what we can measure, and I'll get to this in a moment, is you can measure the LVOT diameter, and then we know pi r squared is the diameter, the area of a circle. So we can take diameter, make radius, and then find out the area, assuming that the LVOT is circular, okay, which it might not quite be, but it's close. And then we can use pulse wave Doppler to measure the blood flow within that LVOT. And pulse wave Doppler, when you trace out the PW trace, you get a distance. It's called the velocity time integral. Sorry if I'm losing people. I'll get to this stuff. It's a hard subject to teach. But you multiply the VTI times the cross-sectional area, and now we can calculate the stroke volume. So that's what this cartoon on the left here, this is your pulse wave Doppler or it could be, anyways, in this case, I'll call it pulse Doppler. I put my trace over top, I calculate the given area from the machine, it tells me a VTI, and then I can multiply that by the cross-sectional area of the LVOT. So hopefully I'll get to some examples here. We can work through this. I don't know what I did there. Covered this already. I don't know why. Sorry, guys, I don't know what's going on. So let's go through a example. So this is the heart, of course, and we want to start estimating some pressures in places. Okay, so there's the right atrium, and I want to know, we'll start with the pressure there, and we'll work our way through a little bit. So we could either just pull a number out of a hat for right atrial pressure. We kind of know what CVPs might be. But if we try to be a little bit more scientific about it, we'll look at the IVC, and now we'll consider our bedside focus or focused ultrasound, and we'll put it on a sort of a subcostal view, and we'll get the inferior vena cava, which is very doable. So pull out your machines and look at your patient's inferior vena cava. And this is the inferior vena cava, and to the right of that turquoise circle or squarish thing is the heart. So that's your inferior vena cava. You can push freeze, you can measure the diameter, and you can actually ask them to take a sniff. And not the most powerful sniff ever, just some sort of moderate sniff, and that will look at the collapsibility of the inferior vena cava during that measurement. And so if the IVC diameter is less than 21 millimeters, and it collapses significantly or greater than 50%, then we're probably a normal CVP like us here, okay? And then there's an indeterminate range, as in everything, and then there's a more congested range, which is the IVC diameter is greater than 21 millimeters, and when they sniff, you don't see it collapse at all, okay? So then we can come up with estimates of the right atrial pressure based on this. 3, 8, or 15 are the sort of rounded numbers in the middle of those ranges, okay? So now we've got an IVC, a right atrial pressure that we can use, and now we want to calculate the right ventricular systolic pressure. And why we want to do this is to look at the pulmonary artery pressures. That's what we're getting to, just so that you guys don't wonder where the heck I'm going with all this. So to get the right ventricular pressure in systole, we'll have to look at another event in systole, which is tricuspid regurgitation. And thankfully, most of us have at least a little bit of it. It's okay to have trace TR, or maybe a bit more and tolerate it okay. So we'll look at the TR jet, which is that blue arrow there. And if we can get an incidentating beam across that and measure the TR jet, then we can start to measure, using that Bernoulli equation, the pressure drop across the tricuspid valve. So we can add that to the right atrial pressure and get the RVSP. Okay, so what we could do is, here's our apical 4-chamber. The probe, you can't see, it's hanging off the bottom of the figure, but we should be practicing more. I'm telling that to myself as well, but it's quite doable. So on the right-hand diagram, you always have your echo, and on the left-hand side is the right-sided structures, and on the right-hand side is the left ventricle and the left atrium. All right, so we're going to put our incidentating beam right across. We'll just swing it such that it goes through the tricuspid valve. We could put color flow on so that we actually see the TR. And then we're going to get the TR jet, okay? And then we'd push pause, and then we'd move our cursor. You can see they move the cursor down to the tip of the tricuspid jet. And then the machine has kindly given us the max pressure gradient, which is 76 millimeters, okay? Is it okay, Michael? No, it's not. Yeah, all random images from the web. They're sanity checking everything. So basically we've gotten 4 meters per second is our tricuspid jet velocity. And what was the equation, Paula? Simplified, yeah. Yeah. Anyway, so 4v squared. So the pressure change is 4v squared. So we could put it in here. Oh yes, this is just trying to represent the whole heart. Yeah. This is actually very darn good because you'd be surprised what we tolerate in TEE for now. The aortic valve we line up well, so that's one we often operate on, so that's good. But sometimes for the tricuspid, I'm quite off. Right. Yeah. So this is actually pretty good. So we're lined. I didn't show the jet here, and then this is kind of similar. They've made it more rightward, and then the jets. Yeah. And then again, 4 meters per second. I wanted to go through some calculations here, but now I'm feeling like it's harder to make you follow me. It made sense to me when I was making it, but the pressure change, you do high minus low. So the high pressure is going to be in the RV, and the lower pressure is going to be in the RA, and the jet's going to be between that, right? So if you get the RV pressure minus the RA pressure, then that's the pressure drop across this distance. We're also measuring the pressure drop across that distance, which is going to be 4 Vmax squared. If we put those two things together, which is what I've done there, 4 Vmax squared equals RVSP minus RAP, we can solve for the RVSP, which is really not that intimidating. You take the right atrial pressure, and you're going to add in your tricuspid velocity, square it, times it by 4, and now we get an RVSP. That's where it comes from. Now, if you don't remember that, that's okay. But what I want to point out is when you see echo reports and you see the RVSP, that's what they're talking about. It's a measure which of the pulmonary artery systolic pressure. Sorry, John. Please go ahead. Right. Right. But we are lucky because we have a central venous catheter, so we just measure it. So, so there's so many things that your eyes glosses over an echo report. I'm just trying to say that the RVSP is a useful measure, and so some cardiologists say if it's greater than 2/3 of your systolic blood pressure, then it's very severe. You could think of greater than 75 is the number I kind of hang my hat on is being severe. 50, yeah, sorry. Good point. It does not. Yeah. And pulmonary stenosis is quite rare if you're not dealing with a congenital population. So I try and hunt down a lot of pulmonic valves, and I find they're like trace PR and yeah. 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 Okay. Oh, okay. Okay. Yeah, I was wondering about that. Interesting. Huh. Oh, that's good to know, and that's where it comes in the RAP factor there. So, um, yeah. And if they have a right heart cath, then things are a lot more accurate. Right. All right. So I want to talk briefly in the last couple minutes about the continuity equation as represented for the aortic valve. And this is where you see the aortic valve area is 0.7 centimeters squared or whatever. This is where the calculation comes from. And so you have two volumes which essentially have to be the same because it's the continuity equation or law means that all the blood's sort of going down the LVOT, so it's going to be ejected out the aortic valve. Okay, so there's that light blue cylinder and there's the reddish one, and those are the same volumes, but the velocity that the blood is traveling during that unit time interval, if you will, is different. Did I say velocity? The distance. And then the areas are obviously different as the area decreases down to the stenotic aortic valve. That's going to change. So that's the continuity equation with the aortic valve and the LVOT there. So flow entering the LVOT is going to equal flow entering the aortic valve. Okay, the area of the LVOT times what we call the velocity time interval, or the stroke distance, which is again measured from that pulsed wave Doppler. That is going to, and I'm not doing a great job of explaining this, but that area times that distance is going to equal that area times that distance. And so if we solve for the area of the aortic valve, then we can, that's how we solve for the area of the aortic valve. Right. So the area of the LVOT, we were talking about, we can measure that, okay? So we could put our parasternal long axis. I figured this is what they do in the echo lab, but I'm learning now that they don't. But you have a parasternal long axis. You can see our echo probe here. This is the orient people. This is the aortic valve, okay? It should be open in the FRL, but I can better see it. This is the LVOT, the left ventricle. This is the left atrium, mitral valve, okay? And it actually is a pretty reasonable image to obtain. You can do it. Oh yeah, good point. No, I know. So this is the aortic valve, and now I've taken it different part of the cycle. It's open, which is when you should measure the LVOT, and you can use the zoom feature on your echo. You can zoom in on the valve. You've frozen it, and now you can measure the LVOT. And so now you're moving towards one part of your calculation. Okay, so half that will be the radius. Pi r squared is the area in the LVOT. Okay, now I need to obtain the flow within the LVOT. So Dr. Ramson will be mad at me, but the insulating beam is not perfectly lined up. But this here now is almost a 4-chamber view, but it's a 5-chamber view because the LVOT has opened up ever so slightly here. And so if you were to put color flow Doppler, you'd see that there's turbulent flow through that aortic valve. And so if we put this beam down it, and in fact we put our little gate right in the LVOT, we can measure how fast the blood's moving there and what we call the stroke distance, or the VTI, using pulsed wave Doppler. So we'll go ahead and, this is a view that we use on TEE, a deep transgastric view. And you can see we get a very nice view of the put our beam down there and then measure a point in the LVOT, okay? And then we'll get this PW image. If we were to trace out that whole envelope, we'd get a VTI, and this is for our equation. Oh, something didn't show up in front, but this was going to be a CW. We'd trace that, we'd get a number. And then this is a very good website called CardioMath, which is by the Canadian Society of Echocardiography. And basically you can put in these numbers that you measure or do the math yourself. It really isn't that hard, but you can put in the VTI for the LVOT, for the aortic valve, and then your LVOT dimension. And then it will go and spit out your aortic valve area at the bottom, 1.7 centimeters squared. If you put in the patient's weight, then it's going to index it to their size, which is really important because some patients can be quite huge and that valve is not good enough for them. And that can be important for when we put in a prosthetic valve. So I apologize if I've raced through. I had aspirations to cover so much stuff, but I realize it's just better done over a number of lectures. But I would say this inspired me to hone my skills again. It's much more doable than you think. And there's that Toronto website for transthoracic echo or the Focus, and we should have it in our lab computer. And when you have a delay, just go grab our great CX50 machine. Just do a parasternal view. Try and get the aortic valve. Try and get an apical. Try and line up your beam. And it's just sort of the mechanics first, and then you can start to apply the information. And this is stuff we're doing all the time in heart room. So if you have a second, come on in and we can line up down the aortic valve and show you this stuff in a TEE environment.